The Ultrasound Leadership Academy is a nonprofit whose purpose is to disseminate ultrasound knowledge. This is essentially an online fellowship where we give you a year-long curriculum and one-on-one hangouts and support that you need to learn this really life-saving modality for diagnosing diseases as well as procedural guidance like nerve blocks, like ultrasound-guided IVs, like central lines. If you want to know more, just check out the website, ultrasoundleadershipacademy.com, where you can reach out to us if you have any questions. Now, we have a bunch of professors, and we give grand round lectures every month or so, and we have all these recorded, and I'm slowly going through and editing them and making sure that they're ready for a general viewing. Now, with this one specifically, I was having a little issue with my computer, so I couldn't separate the Zoom from the screen recording. So that's why you're going to see a few kind of blocks, almost like there's a huge pixel out on the side of the screen. That's just to protect some of our fellows, their privacy, basically, to make sure that they're not names and pictures aren't on there. So that's why that's there. The lecture that we are going to show you today is me talking about pericardial tamponade and why I don't think that it should be considered a clinical diagnosis. Check it out. Okay, now if anybody can't hear me, make sure to mention it. And if not, if you don't see me like answer you, just unmute yourself and let me know, because I want to make sure that you can hear it and see my screen. Since I see nobody say, I can't hear you, I'm going to just like go on, just go for it. All right. So what we're going to talk about here is pericardial effusion and tamponade and why I really don't think that it should be considered a clinical diagnosis. Now, I know that that is a bit controversial. Like I get it, but here's the thing is that people who call it a clinical diagnosis are the people who don't have bedside ultrasound. And if you have bedside ultrasound, you really should use that to diagnose tamponade, not your clinical exam. Now, I'm going to kind of explain why here. So this right here, this is a study. It was published in 2001. It was a long time ago, included a good amount of patients. It was 515 patients. And it was this retrospective review that looked at basically all echoes. And they found out that us point-of-care providers, so EM doctors, we had a sensitivity of 96% and a specificity of 98% for being able to diagnose a pericardial effusion. So we can do this. We can diagnose this at bedside pretty easily. And that was in non-trauma patients. This study, also a bit of an older study. It was kind of in the wild west of ultrasound, 1992. Actually looked at trauma patients looking for cardiac injury, and they included 49 patients that had penetrating cardiac injury. And they found out that in those patients, 100% of the patients that had ultrasound and had penetrating cardiac injury, they actually survived. Whereas those with penetrating cardiac injury that did not have that ultrasound done, they had a 57% survival rate. I know what you're saying. It's correlation. It's not like a randomized double-blind study. Like I get that, but this is the data we have. It's very hard to randomize patients to get ultrasound and not, and something that ultrasound is obviously helpful for. But this is the data that we have, and it shows that we're pretty good at this and that it can actually save lives, presumably because you can diagnose that tamponade and you can actually do something about it earlier rather than later. All right, let's talk about the how. How do we actually do this? I think that at this point in our kind of medicine career and in ULA, we probably know there's four main views, right? We got our parasternal long, our parasternal short, our subxiphoid, and our apical four-chamber view. Now, any of these can diagnose a pericardial effusion and can diagnose tamponade, but probably the one that we're going to hear about the most and the one that is most often talked about is going to be this one right here. This is the subxiphoid view. Now, the subxiphoid view, it's a little bit different than the parasternal or the apical views because you're basically trying to get the probe just basically underneath that xiphoid process, almost like you're scooping out the heart in like a little ice cream scoop. So you want to get it underneath there. Sometimes you have to push a little bit, but most of the time patients can tolerate it pretty well. And you want to identify these structures right here. So we have our liver up here. We have the right side of the heart over here, right ventricle, right atrium, left ventricle, left atrium, valve, valve. This is a subxiphoid view that does not have a significant pericardial effusion, whereas this one right here does. Remember, fluid is a hypoechoic thing because it doesn't have any echoes that come back to it. This is a pericardial effusion surrounding this effusion. You can see it's all the way around. It's a pretty, at least moderately sized effusion. Now, in the previous examples, I'm using the phased array transducer. You don't need to use a phased array transducer. You can actually use the curvilinear transducer as well. And it can actually give you a higher resolution image, although the frame rate or the temporal resolution is a little bit lower. Notice in this clip here, it's a bit on the choppy side, right? But we can see an effusion just the same with this curvilinear transducer. And in fact, when I'm doing a fast exam in a trauma patient, if I happen to be doing the abdomen as well as the chest, I usually don't switch transducers. I go subxiphoid with the curvilinear, and I'll even look for lung sliding with that curvilinear transducer, as well as looking for intraperitoneal free fluid. So I do the whole thing. Now, this right here is an interesting pericardial effusion. So I've already diagnosed this pericardial effusion. This is not really like the best view per se. What we can do is we can kind of zoom in and we can actually see this little strip right here, right? So we're seeing this strip here. And the question is, how do we diagnose this as a large or a small? Now, this is it's something that's subjective, but there are some studies that say that if you measure this and it's less than a millimeter, it's small. If it's between 10 millimeters, so it's 1 centimeter. If it's between 1 and 1.5 centimeters, it's a moderate. If it's greater than 1.5, it's considered a large effusion. But you just kind of eyeball it. If it looks like a little strip, it's probably small. If it looks like a large amount of fluid, then it's large. And if it's in between, it's moderate. Now, let's talk about some of the other views here. This is a parasternal long axis view. We can see here the left atrium, mitral valve, left ventricle, aorta over here, and then we have the RVOT up top here. Now, what I like about this view is you have this thing right here. You have the descending aorta, and this can actually help you differentiate between a pericardial effusion and a pleural effusion, especially on that left side, because if it's anterior to it, it's a pericardial effusion. And if it's posterior to it, it is actually a pleural effusion. So here's same view, both parasternal long axis views. We see the aorta here, we see the aorta here, and we can see this fluid going anterior. See how it's kind of aiming more anterior or above that aorta? That is calling this a pericardial effusion. Now, I'm going to wait here at the end of the clip here, and you can see here that there might also be, actually there is, a pleural effusion as well. So this line right here basically separates the pericardial effusion from the pleural effusion. But on this view right here, this fluid right here is pericardial, not pleural, because it's going anterior. So here's another example here. We see this fluid going over top of that descending aorta, making it a pericardial effusion. Now, on this clip right here, this is basically both. It's a better example of it. We see the same parasternal long axis view. We see the descending aorta, and we see fluid going anterior to the descending aorta. But also, we see fluid posterior here. So this is actually a pleural effusion as well as a pericardial effusion. Now, we can also obviously look at this in other views. We have the parasternal long over here, and we have the apical four-chamber view over here. And we can see this hypoechoic fluid collection here. We see a hypoechoic fluid collection over here, and we can see effusions with both of these. But for me, I kind of start off with a subxiphoid, and then I'll move on to the parasternal long axis view if I need to, or if I can't get the subxiphoid view. Now, one thing that we need to talk about is what fat pads look like, because especially in our older population, they can kind of confuse us sometimes. So this is a kind of an interesting like view in general. So let me walk you through where I'm at. I'm actually in the subxiphoid region, and I'm shooting up towards the heart, right? Because I have the probe down here and I'm shooting the beam upwards. So this right here is actually acidic fluid. This is a peritoneal free fluid in the setting of ascites. And then here's diaphragm. And then right here, we see a little sliver of free fluid. And the next thing we're seeing here is a pretty large pericardial fat pad. This is not clot. This is not a big kind of complex effusion. This is a sliver of a pericardial effusion and a pretty big fat pad. Now, I know it's a fat pad because I can actually see that it is moving completely in sync. It's not like waving, kind of like moving because the heart is moving. It's moving because it's attached to the heart. It's stuck to it. So if you see something that's stuck to it, it's got a mixed echo texture. It's very likely going to be a fat pad. Okay, so that was a pericardial effusion. Let's talk now about what to do with it, right? A pericardial effusion in of itself it's always a thing, right? But it's not necessarily something that is clinically significant, right? When it becomes clinically significant is when we think about tamponade. How do we know this patient with a pericardial effusion has tamponade? I talk really fast. Okay. So I just wanted to make sure no questions. I'm going to look here in the chat real quick. All right. I think that we are okay with the chat. All right. So what I'm going to do is I'm going to go ahead and save screen again. Just wanted to check in on everything, make sure everything's okay. All right. Let's go back to share screen here and let's go back to our lecture. All right. Now, tamponade. This is kind of like the big thing here, right? Oh, yeah, we don't need this. We're going to move this over here. There we go. All right. So this is why this whole concept to me is important is we think about tamponade. At least I was taught that tamponade is a clinical diagnosis. This is something that you as a detective, physician, or provider, you're going to sit there and really like take time and think about it and do a bunch of maneuvers, a bunch of like JVPs and a bunch of this stuff to try and figure out exactly like, is this tamponade or not, right? Now, if you have a crashing patient, like they are like hypotensive, they're pericode, and you see a large pericardial effusion, that's not like what this discussion is for. This discussion is for kind of the borderline case that you're not sure if this is causing hemodynamic compromise rather than impending hemodynamic like arrest, right? Now, let's talk about Beck's triad. Now, Beck's triad, we all learned it in school, and we learned that it was it muffled heart? I got to think about it. Muffled heart tones, elevated JVD, and I think arterial hypotension. I don't remember it because honestly, I think it's mostly useless. It might be a little bit on the specific side, but it's definitely not on the sensitive side. So let's talk about where the data for this came from. Where did the data for Beck's triad come from? It actually came from this article. Now, I'm not like an antique person. Like I don't go to antique fairs, but also I like vintage looking things, right? This was a study in what would turn into the JAMA, the Journal of the American Medical Society, published in 1935. And this is where Beck's triad came from, 1935. Now it's really cool. I actually had to buy this article because it's sold. It's not even on PubMed. I bought it. It cost me like $40. And look at these graphics. They're just so cool. Actually, I'm going to rewind that right here. Look at how cool these graphics are. Super vintage. I love it. But let's talk about like what the research was, right? This was like before the research kind of like existed, before like we had to do randomized double-blind placebo-controlled trials, right? Here is the data that was supplied. And I quote, Dr. Robert Dinsmore observed the development of the acute compression syndrome, so Beck's triad, from mediastinal hemorrhage following the removal of a substernal goiter. Acute compression develops also when fluid other than blood forms rapidly in the pericardial cavity. And I can keep reading, but literally the evidence here is like one dude that this guy knew that also saw this. So it's two people that observed this in two patients. That's where this evidence came from. So very, very poor. Poor is not the right word. But I'm going to use it because I'm trying to be respectful. Very poor evidence behind this. Cool graphics though, right? Now, there have been studies that have gone forward and actually looked at the accuracy of this, and the specificity is not bad, right? So if they definitely have tamponade and they have all these three signs, they probably have tamponade, right? But let's look at these sensitivities here. So these are sensitivities of these findings: hypotension, diminished heart sounds, and elevated JVDs. We have one study that showed that elevated JVD had an 88% sensitivity, another one that showed 74. So these are not bad, but look at the rest of these numbers, right? 14% sensitivity for hypotension, which is the one that we always think about with tamponade, right? So we can't use this test to rule out a disease. And whenever we're working point of care, We always want the more sensitive test rather than the most specific test. Now, this took me a while, but I looked up as much as I could all of the studies that looked at how many patients actually had hypotension when they had diagnosed tamponade. So this is tamponade in the cath lab, basically. So they either had a cardiology echo or they actually had a cardiac cath in place showing exactly what the pressures were in the heart. And they found pretty poor numbers here. At most, 36% of patients in tamponade. They had the gold standard of tamponade. So they had tamponade. At most, 36% of these patients actually had hypotension. That's actually kind of scary, I think, right? These are numbers. These are mean blood pressures. And you can see here, these are the mean blood pressures of hypertensive patients. Like, look at these numbers here. This is the mean blood pressure. And these studies that actually had tamponade, you can see here that quite a fair bit of them actually had hypertension with tamponade. Hypertension, had a high blood pressure. And that actually makes sense because what you're doing here is you are seeing, in these cases, you are seeing that a patient, when the body detects hemodynamic compromise, is doing what the body needs to do. It is increasing the catecholamines in the body via adrenaline, via the adrenal glands, which is artificially bumping up that blood pressure to compensate for that lower stroke volume due to diastolic collapse of that ventricle. Makes sense. Now, for me, what we do, if we wait until a patient crashes to do something about that tamponade, we are waiting basically for them to die. We're waiting for them to die before we can do something about it. And I love doing procedures, right? But I don't think that we should be doing procedures late. I think that we should be doing the procedures that will help them to not decompensate rather than doing reactive procedures when they decompensate. This is actually, this makes me super nervous here. I'm a little bit uncomfortable. So this is a home. I forget where it is. It's in Texas, I think, over like a Texas kind of lake. I was trying to see where it's just Lake Whitney, right? Gorgeous home. Like, look at this great driveway, but it's kind of close. And I noticed that it was eroding a little bit. And then this happened, right? Over time, this happened. And then this happened. This to me is a great, I mean, this is horrible, right? I mean, this is a home, this is like important, and I feel very bad for this family and that this happened. But I want to use this as a bit of an educational kind of tool to demonstrate how I feel about tamponade. Like, wouldn't it be great if back here they were able to, I don't know, reinforce this? They probably had time to evacuate the house, which is great. You want to like address this problem here when there's impending collapse rather than here when it's actually collapsing, right? So that's why it's so important. And remember, tamponade itself, it's not like an on-off, it's a gradual grade. So patients will slowly start to decompensate even if their blood pressure is high because their catecholamines are working. And then they'll reach this level where they have nothing and then they crash and they die. And that's what we want to avoid. This is an actual case that I had. It was early after I was done with my fellowship. It was probably it was the year after my fellowship. And there was a patient came in, young patient, got shot in the right chest. Hypertensive, mildly tachycardic. So it was like 105, 108, fit person, right? And hypertensive. And we did a fast exam. The abdomen had a little bit of free fluid, but they were going to get a CT scan. That was the plan because they were hemodynamically stable. Had a pulmonary contusion, but no significant pneumothorax. But I see this, right? So this is not a great view because you can see here, see the bobbing of the diaphragm here. The patient's he got shot, right? They're breathing heavily because they're in shock and also because they got shot. And I can see here that I can see fluid right here, and I can see a little wiggly clot right here, a little wiggly clot. This patient was hypertensive, mildly tachycardic. The surgeon, thankfully, was actually was the chief surgery resident when I was a resident, so she knew me. And I told her, I said, Jessica, please, can you just take this patient to the OR? And I showed her the image. She's like, we're taking this patient to the OR. Took them upstairs. They were able to fix this hole in the right ventricle that was causing this pericardial effusion. And the kid walked out of the hospital a few days later. Now, imagine if we would have waited, we'd taken the kid to the CT scan, which, we need to do sometimes, right? But imagine if we had waited because the patient was not in hemodynamic compromise, this patient might have died. They might have had an ER thoracotomy, which the likelihood of patients surviving those is low. And it's not like the thoracotomy is bad for them. It's just if they get a thoracotomy, they're already super sick, and a thoracotomy is like a last ditch effort. And I believe that we saved this patient's life because A, we had the ultrasound at bedside, and B, we were able to conceptualize the idea that hypertension does not mean the patient is not in shock. It means they're in compensated shock, but they could still be in shock. Now let's talk about how useful identifying tamponade in arrest is in general. So that was trauma, but this is like in an arresting patient in general. They quote that the survival rate for people who get, so this is all comers who get CPR, is 4%. It's pretty low. 4% of patients are like really different from TV shows, right? Now, if we look at the data that exists, and this is data that we have, when patients have tamponade, this is patients that what percentage of patients in arrest have tamponade? It's not an insignificant amount, 4.3 to 8%. So it's not like every patient has it, but it's a decent amount, right? Now, if we look at these numbers by themselves, we can actually, based off of the Reason trial, we can actually see that patients who got a pericardiocentesis had a higher survival rate, and these are arresting patients, than those who did not. Which this means to me is that if you identify tamponade as a cause of arrest, they're much more likely to survive, assuming you fix it, obviously. They're much more likely to survive than if not. So that's why identifying this is super important. Now, let's talk about what this is. So a tamponade is the presence of a pericardial effusion plus it's an either or, right atrial diastolic collapse, right ventricular diastolic collapse, pulsus paradoxus, plus a dilated IVC. So this is actually, and I'll talk about why I think this is pretty important for me. It's more important in kind of borderline cases, but I use it pretty much every time. Now, most of the data for this actually comes back, if you like track it back, it comes back from this one study that was done in 1983. And it actually showed the data for right atrial collapse being the earliest finding in tamponade. And they found that the sensitivity of this was 100%, but the specificity was 82%. Now, let's talk about stats, right? Anything at the bedside that has a sensitivity or specificity above like 80-ish% is actually really good. Like all these bedside tests that we have, like lab tests, like a BNP, like a white blood cell count, their sensitivities and specificities are about here, right? So for a bedside test, this is really good, but it's something to remember is that the presence of RV diastolic collapse is 100% sensitive, but it's not 100% specific. So if you see that right atrial diastolic collapse in the setting of a pericardial effusion, it could definitely be tamponade. But if you want to bring that specificity up, you actually have to look at something that's called the ARRE inversion index. And what that is that's identifying that the diastolic collapse occurs for greater than 1/3 of the cardiac cycle. That actually brings the specificity up to 100%. It does make the sensitivity dip down just like a little bit. I'm not 100% sure why that is actually, but it makes it down a little bit. So something to keep in mind, it has to be a prolonged RA diastolic collapse for it to actually be 100% specific. Now, the one that most of us use, because I think it's probably the easier one to diagnose, and it's the one that without any kind of calculations is 100% specific, is the RV diastolic collapse. Now, I didn't misspeak. It is diastolic collapse of whatever chamber it is that you're looking at, right? So it's right atrial diastole. That's that collapse, and it's a right ventricular diastole. So what it is systole is when a chamber is squeezing, it's ejecting, and then diastole is when a chamber is enlarging. And this helps me understand when you're supposed to look for which, because just conceptually, if the chamber that's trying to fill is being collapsed, that is obstruction. right? So that makes me that makes it a little easier for me to remember. So it's RA diastolic collapse and RV diastolic collapse. Both of those are indicative of tamponade. Now let's look at this image right here. So this is probably an apical 5-chamber view. We're seeing a large pericardial effusion over here. And let's look and see when exactly this RA is collapsing. So what we're going to do is we're going to slow it down, and we really want to look at the valves right here, right? So the atrial diastole occurs when the valve, in this case, the tricuspid valve, the valve is closed, right? Because that valve is closed, it means the chamber is trying to fill. And we can see here that when the valve is closed, right there, valve is closed, and we have a dip. Let's see right here, valve is closed, and we're seeing this dip here. This is right atrial diastolic collapse. Valve is open, boom, it pops out. Valve closes, it pops in. This is atrial diastolic collapse. There is also, let's see, a little bit of ventricular collapse as well. So we see here, see the tricuspid valve open, and then we see a little dip in that RV. So this is actually both right atrial and right ventricular diastolic collapse. Now let's look at this one right here. This is kind of like a oblique apical 4-chamber view. This is the right side of the heart over here. We have kind of a weird view of the left side of the heart over here. Let's go ahead and slow this down. We see an effusion, by the way, up here. So that's why we're even asking this question. And we see here that when the valve is open, that's when you see collapse. See, it's closed, it doesn't collapse. Open, it collapses. This is actually systolic collapse. So this is actually normal. The atria is if it collapses during systole, it's just it ejecting the rest of the volume that it has in it. So this is not tamponade, even though it is collapsing and there is fluid. And that to me is very important. You can't just call something a trampoline sign, because somebody can have a pericardial effusion and be hypotensive from blood loss, right? And they're going to have a very vigorous systolic collapse of the atria or the ventricle, which doesn't mean they're in tamponade. It just means that their heart is pumping fast. It's trying to get rid of all its fluid, of all the blood inside of it, inside the chamber, and not necessarily indicative of tamponade. This is a parasternal long axis view showing a quite large pericardial effusion right here, right? So all this is a pericardial effusion. We have likely a pleural effusion down here. Actually, it is a pleural effusion down here. There's the aorta. Now, when we're looking at a parasternal long axis view, we can still evaluate the right ventricle and figure out if it's diastolic or systolic collapse by looking at the mitral valve. So basically, if the collapse happens when the valve is open, that is diastolic collapse. Whereas when the valve's open, the chamber pops up, then that is only systolic collapse. We're going to slow this down. I'm going to pause it. I'm going to cycle through, and you see here, the mitral valve is open and the RV free wall is collapsed. This is showing us that this right ventricle here is collapsing during ventricular diastole, making it tamponade. Now remember, this is irrespective of the patient's blood pressure. Most of the time, I will kind of concede that most of the time the patients are tachycardic, because that's what adrenaline does, but nothing to do with the blood pressure. Now, on this view specifically, on the parasternal long axis view, you can actually drop M mode through here, just like you would for an EPSS. Like this right here, this is the septum. This is the E wave right here. So this, you can still do like EPSS here, but you can look at a different part of it as well, like while you look at the mitral valve. And that's looking at this guy right here. So remember, there's markers here. And just as a review, M mode is basically a graph of every movement that happens along this line in the y-axis over time in the x-axis. And so this right here, this is the valve opening. Remember, the mitral valve opens up twice in the cardiac cycle. This is the E wave. This is the early diastolic filling, which is caused by the pressure difference between the atria and the ventricle. And then this right here is the A wave, and the A wave is the atrial kick. So when the valve is open, that is going to be diastole, right? So what we can do is we can actually say, hey, this is open, right? So from here to here, this is diastole. And then this being the RV free wall, it's dipping. So it's dipping in diastole. It's a dip during diastole, dip during diastole. This is confirming that the patient has sonographic tamponade. Now, the last thing that we can talk about is respirophasic inflow variation. It's the same thing as pulsus paradoxus. I will let you know that off the bat, this one I'm not a huge fan of. And the reason why is because the heart itself, when the heart is in distress, it can actually wave back and forth within the pericardial effusion sac, basically, just like, you have the what's it called, pulses, I'm struggling with the word here, but on an EKG, you can see the QRS intervals. They kind of will go up and down, and that's indicative of like the electrical alternance. That's the word. That is like the heart kind of swinging back and forth in the effusion. When you have a patient that has tamponade and you throw pulse wave Doppler through the gates to look for this actually variation in velocity, remember, if your pulse wave Doppler gate is right in the middle of flow, it will be a velocity. And even if you change nothing else, right? If your pulse wave Doppler gate shifts off to the side where it's less of that laminar flow, the velocity is actually going to go down just with you moving the pulse wave Doppler off midline. So if the heart's waving back and forth, your pulse wave Doppler might not be measuring the exact same location of flow and might artificially give you different values than you actually have. So that's why I'm not a huge fan of it, but occasionally I'll use it, and it's something that's talked about. So you'll want to go ahead and just know about it. Now, there is normal variation. There's normal variation because patients, when they breathe, they're going to change the amount of pressures that are in their chest. So there's normal variation. But through the mitral valve, if it's greater than 25%, and then difference between the two peaks, the highest and the lowest velocity, and then through the tricuspid valve, 40%, that's considered abnormal. So let's take this apical 4-chamber view right here. And we are going to put a pulse wave Doppler gate through the tricuspid valve and through the mitral valve. And we can see here that if we measure the peak here and the peak here, this is probably greater than 40%, maybe right about 40%. And then for the mitral valve, we take the peak, which is here-ish, right there, and the trough right here, probably around 25%. So this is kind of how you would measure that. Now I'm going to take a little pause here. We have a couple of questions. We have two from Sayonara. Hello, good to see you again. First question is, are there any features to differentiate a clot from a fat pad? And there's not a whole lot of sonographic features. It's really just the appearance of the clot itself. If it seems like the entire strip of the thing that you're trying to consider as a clot or a fat pad, if it seems like the entire strip is just completely just on that heart border, then that's a fat pad. Whereas if you see something similar, but you see the heart kind of waving and the thing is kind of bucking off of it, like it's only maybe attached on one end and it's kind of just waving with it, not actually fully attached to the cardiac border, that is more likely to be a clot. So it's just kind of the appearance of it. And just being able to think about the clinical story as well would actually be helpful. If you have like a diabetic patient that is chronic volume overload, less likely to be clot, right? Because less likely to bleed. Whereas if you have somebody that had a gunshot wound to their chest that's young, very unlikely that patient has any fat pad. So some of it's clinical context as well. And then I have another question here. What if the patient has diastolic collapse, but an empty IVC? Last week, I gave the patient's fluids and the ARRE stopped collapsing. And she's asking, sometimes tamponade is just a question of fluid imbalance, right? And the answer is yes. And I actually, I might talk about in this lecture. I'm going to see if we kind of have time for it. But there actually is case reports within the emergency medicine literature of tamponade being present with a flat IVC. So remember, with anything in medicine, not just with ultrasound, but anything in medicine, there's always going to be exceptions, right? There's always exceptions. And sometimes in very rare cases, you will have a low CVP and have a patient in tamponade if they're exceedingly fluid behind. So yeah, that can definitely happen. And thank you for that question. All right. So that is tamponade. Let's talk about a pericardiocentesis, what to do about it. Now, this is like the next step, right? And this is like it's one of my favorite procedures to do, is a pericardiocentesis. I am not happy that patients will need this. But if patients do need this, I want to be the person that helps them with this. You can go subxiphoid. You can go apical 4, you can go a parasternal long axis view. This is a classic view, but I will tell you that this approach is my least favorite because you have to go through so much of a distance to get to the pericardial sac all the way up here. And you're going to go through very likely the liver and like invariably you have to go through the diaphragm to get up there. And also sometimes it's really hard to get your probe and the needle under here and get it all like adequately visualized. My second best is going to be the apical 4-chamber view. Remember, if you can see the effusion, so if you can see the whole effusion with your probe, it means that directly under your probe, there is nothing, there's no lung basically. Because if there was lung between your probe and the heart because of the air, you wouldn't see the heart. So if you can see the heart, there's nothing between there. And probably the best way to do it, if you happen to get a good window, if you happen to have a good amount of fluid there, is going to be your parasternal view. So this right here, this is an apical 4-chamber view. This is a patient that was very peri-arrest, had a history of heart failure, has an effusion here. I'm using the curvilinear transducer. And then here's my needle right here coming into view and draining that fluid. Now, one of the reasons I like to keep all of my ultrasound exams is because when I see this now, this is done in residency, and I know that like this is great because I can see the whole heart, but I don't need to see the whole heart. I should have had the depth to like here, because really all I need is I just need to see my needle, the pericardial fluid, and then the cardiac border. That's really all I need. What I should have done is I should have had it to this kind of depth right here. So you see how this is and you can see how easy it would be. You can actually see me pushing the skin over here. How easy would it be for me to track this down to this pericardial sac and be very careful and very diligent to not poke that RV? So this is probably the best one, best depth. Now, if you can use the linear transducer, look at this resolution. It looks so good. And this is all you need. You just need the chest wall, the pericardial sac, and just the most superficial border of that heart. That's really all you need to get a good view. Here's an example. Here is a apical 4-chamber view. You see this big effusion. Over here, you see the needle with the linear transducer. I'm actually advancing the guide wire here. This is before, this is the procedure, and this is afterward right here. So significantly better. We have a better ejection fraction. Patient did okay. Here's another one right here. This one I'm using the phased array transducer. You can see that needle up in here. Again, a little self-reflection. We definitely do not need this much depth. You can see the needle there. You can see the J tip of the guide wire there. We're doing something here called a little flush test. So if you're not sure if you're in the pericardium or in the ventricle, you do a flush test. What you do is you aspirate a little bit and then you inject either a little bit of saline or that blood, just a little bit of it back in. And if you see bubbles or turbulence within the sac, you're in the sac. Whereas if you see turbulence within the right ventricle, you should pull back a little bit because you're in the right ventricle. Here's an example of actually performing one. You can see here that sometimes your technique's going to be a little atypical. This is obviously on a mannequin. There's actually Ben Smith's hand here. You can see here that this is very doable at the bedside. Now, one thing that I want to mention is the utility of using the IVC. The IVC is actually pretty helpful. In borderline cases, what I'll do is I will actually I will look at that IVC. If I'm not 100% sure, or it collapses sometimes during diastole, and sometimes the RV collapses during doesn't collapse during diastole, I'll look at the IVC, and most of the time, the vast majority of the time, the IVC will be plump if the patient is in any kind of hemodynamic compromise due to that pericardial effusion, right? As Sayonara mentioned, there definitely are times where you're going to have a flat IVC, but those are exceedingly rare. And you remember, you're not just using your ultrasound. You are using everything at your disposal, including the history and physical examination. You're going to take all of those components, you're going to add your ultrasound to it and decide what is the best course of action for this patient. Sometimes it's more imaging. Sometimes it's a consultation with your cardiologist. Say, hey, I think this patient might be in tamponade. And that's okay. You're not doing anything wrong by asking for help. But if you have a clear-cut case where the patient has ventricular collapse, ventricular diastolic collapse, they have atrial diastolic collapse, they have a plump IVC, even though they have hypertension, they have tamponade. Now, important caveat here is that I'm not saying in that case, if you have a patient that has compensated shock, I'm not saying that that patient needs to have an emergent pericardiocentesis at bedside. That's not what I'm saying. What I'm saying is you have to understand that the patient has tamponade, and if you happen to have a cath lab or a place that can do it within your own institution, like amazing, like call the cardiologist and say, hey, this patient has compensated shock due to tamponade. I need you to take them up now because I would rather them get this done in a sterile, calm environment rather than a crash pericardiocentesis in the ER, which I've done, and I don't like them. I've done pericardiocentesis on awake patients, and I don't like doing it. I'd much rather it happen in the cath lab when they're like sedated or intubated and comfortable and everything's relaxed. It needs to be done there. So that's what I'm saying. And if you have like a long transport time, maybe consider doing it beforehand. It's something that you have to remember that it is a thing. You don't necessarily need to do a crash one, but be able to identify it and put that patient, even if they're compensated, in a kind of like a higher urgency to get that consultation, or higher urgency to actually get other imaging, or further urgency to transfer them to another hospital. Now, I'm stoked that we started late and I still was able to finish relatively on time. Before I end, does anybody have any questions for me? Cool if you don't, but if anybody has any questions, either ask or you can put it in the chat too. Now, I know that can be a controversial topic, but I really believe that we should be diagnosing tamponade before the patient loses their compensatory mechanisms, and we can do that with ultrasound. Again, if you want to know more about the Ultrasound Leadership Academy, head over to ultrasoundleadershipacademy.com. I hope to hear from you soon, and happy scanning.